Good evening, everyone, and welcome to our first of 4 webinars this week that are part of the virtual OT conference. We are just thrilled to see how many people registered and are attending this webinar on a relatively short notice, but we're super excited. We decided to have this conference because, of course, all of you know that our OTs or OT-related students or faculty, that the AOTA conference was canceled, and we were sad because we were really looking forward to meeting you, interacting with you, sharing information with you, and also learning from you as well. So we decided to offer you these webinars this week, and this is the first one tonight, and we'd be happy if you join for our other webinars coming tomorrow and then 2 on Saturday as well. So this webinar is on non-motor features in Parkinson's disease, the role of the occupational therapist in consideration for treatment effectiveness, brought to you by LSVT Global. My name is Laura Gousset. I'm a moderator for tonight's session, not one of the presenters, but I am one of the LSVT Big faculty and the Chief Clinical Officer of LSVT Big. And our main stars of the night are Julia Wood and Erica Vitek, who are very experienced occupational therapists and are 2 of our LSVT Big training and certification faculty. So we welcome Erica and Julia tonight, and you'll hear from them at other webinars that they'll be presenting in during this week as well. Some brief instructor biographies. I won't read them here, but Erica and Julia have had years of experience, and Erica works in Milwaukee at Aurora Sinai Medical Center, specializing in neurology. She leads her Parkinson's program, a Parkinson's graduate class for her LSVT Big graduates, and is also certified in biofeedback for pelvic muscle dysfunction and is a board certified pelvic rehabilitation practitioner. And Julia works at the Dan Aaron Parkinson's Rehabilitation Center in Philadelphia. Julia is also faculty on the Allied Team Training Program for the Parkinson's Foundation and is a facilitator for the PD Self program as well. And she participates in interdisciplinary clinics at the Dan Aaron Parkinson Center for atypical Parkinsonism, Huntington's disease, ALS, and those with DBS. Some brief disclosures for tonight. We have both non-financial relationships and financial relationships with LSVT Global, including a treatment preference for LSVT Big, and also Ms. Vitek and Ms. Wood are consultants, and I am myself an employee of LSVT Global and receive lecture honorarium and travel reimbursement as well. Our plan for the webinar is this. Most of the hour is going to be spent on content presentation by Erica and Julia. However, we will leave some time at the end for questions. And in a moment, I'll give you some instructions on how you can type in questions during the webinar and at the end of the webinar as well, and also go over logistics information and CEU information. So right now, all of your microphones are muted so that there's no background noise from the various environments from which you might be joining. But at the end, when it comes time to ask questions, you'll have the opportunity to raise your hand and ask your question out loud if you choose to. Also at the end of the webinar is a survey, so we really encourage you to fill out the survey and give us feedback about the webinar. And then lastly, in the control panel of your webinar, you'll see a little tab that says handouts. And if you open that, you'll see that there's a handout for the slides for tonight's show, and also a couple of additional handouts. One is related to our plans for this week, and another is related to, I believe, I'm just blanking out on what that handout is. It's a general basic handout on what LSVT Big is for people that aren't familiar with LSVT Big. So in terms of CE activity, right now, if you are in a state that accepts self-reported CE, and you would like a certificate, please email us at the end of the webinar at webinars@lsvtglobal.com to request a certificate that you can use for self-report. Licensing requirements do vary state by state and profession by profession. So if you have any questions about whether your state accepts self-reported CEU activities, please contact your state board. All right, now in terms of asking questions, we have a lot of content to cover, and I would just encourage you throughout the webinar, if you think of a question, to type it into the control panel in your webinar, and we will stockpile those questions and answer those in order at the end of the webinar. The other way that you can ask your question at the end of the webinar is by raising your hand. So you want to click on your hand icon and your name will be called out loud. Make sure that your microphone is unmuted, and then you can ask your question out loud after that. If we run out of time, or if you think of questions later, please do email us at info@lsvtglobal.com, and I'll review these instructions at the end as well. So briefly, these are our objectives for tonight. By the end of the webinar, we hope that you'll be able to define non-motor symptoms of Parkinson's disease and explain how these non-motor symptoms may affect occupation-based performance and participation in people with PD, and provide examples of strategies that may be used in occupational therapy to address non-motor symptoms in PD and potentially improve and maximize treatment outcomes. So with that, I'm going to turn it over to Julia, who's going to kick off our webinar tonight.
Thank you so much, Laura, and thank you everybody for turning out for this. I know that we're all a little isolated probably right now. I see the word pandemic on the screen and I think of a different type of pandemic that we're all living through. So thank you for joining us tonight. So let's talk about Parkinson's disease and how it's thought to possibly be a global pandemic. It's estimated that there's up to 8 million people worldwide who are living with Parkinson's disease right now. And the prevalence of this is expected to double by the year 2040. So if you think about that, within our lifetime, and 2040 seems a long way off, but the older I get, the quicker those years seem to come. We really think that there are going to be a huge amount of people that this is going to affect the lives of individuals and families. And so it's very important as occupational therapists, we're going to get into a lot of how we can help these individuals tonight and really help better quality of life and outcomes for these individuals across their lifespan. All right, so next let's take a look at this background on both the motor symptoms, which I think we more think about with Parkinson's, and also the non-motor symptoms. So a lot of you are probably familiar with those key motor symptoms there on the side, the slow movement or bradykinesia, the small movement or hypokinesia, the rigidity and tremor and postural instability that we expect to see. But what most people don't know is all of these non-motor symptoms that can really impact function and quality of life. And as you're going to see in some of the slides coming up, they impact communication, balance, activities of daily living. They really span all of the issues that as occupational therapists, we really help to address. So you see there are issues with mood and cognition, with pain, bowel and bladder dysfunction, sexual dysfunction, sleep. So it really does span all of the areas of, quality of life, I think, for people, and things that we can help with as occupational therapists. So then these non-motor symptoms, we know now through a lot of research, often predate the motor symptoms. And so the motor symptoms are really thought more to be the tip of the iceberg. And I know for myself, I'm literally on a crusade that we should call Parkinson's more than a movement disorder, because these non-motor symptoms show up several years before the classic motor symptoms, and most people find them more impacting to their daily function and their quality of life than the motor symptoms are. So next, if we look at what do these non-motor symptoms impact? We know that they appear early in the disease, so sometimes even predate diagnosis. We know that they can negatively impact their occupational performance and participation more often even than their non-motor symptoms do. They even seem to exacerbate and interact with the motor symptoms. So we'll get into that a little bit more when we talk about mood. Things like depression and anxiety can really interact with freezing of gait, with mobility, with cognition. And we know that they're also less easily maintained or managed with medications than the motor symptoms. And they're often under-recognized by healthcare providers and by their doctors. And so it's important that we as occupational therapists really get into that occupational profile and see all of the issues that are impacting our patients so that we can make the most, broad spectrum help and treatment across all of these domains. All right, so what's really fascinating, I'd say over the last 10 years, more and more, we're seeing that, rehabilitation with speech therapy, with physical therapy, with occupational therapy is really part of a routine management. So, we know that L-DOPA or Sinemet, those carbidopa-levodopa medications are the best pharmacological management with Parkinson's disease. Deep brain stimulation or neurosurgical intervention is an approach, but speech, physical, and occupational therapy really help empower people to live well across their disease span and live their life to its fullest. So we can help on so many levels. All right, so next, let's take a look at our practice framework. So if you think about, all of these areas that we address, our client factors and performance skills, if you think about all of those non-motor symptoms and put them in there, the cognition, the fatigue, the apathy, dementia, depression, all of the areas that can impact for people among their ADLs, their IDLs, their work and play and social participation. So this really does fit within our framework of how we can intervene and help people live their life to its fullest. So why does it matter to consider those non-motor symptoms? I feel like I've already soapboxed a bit, so I apologize. We know that they can be potential barriers to generalization outside of the treatment room, especially if we're looking at things like apathy or cognitive changes, can really, put up a wall for them being able to carry over what we're working on with them. They are part of a, high intensity repetition and salience. So we have to get all of those neuroplastic concepts in there to really impact these non-motor symptoms as well. And we know as holistic occupational therapists that we view patients as whole people. So we're not just looking at their impairments, we're also looking at their strengths, we're looking at their performance challenges and what they ultimately want to participate in their life. Okay, so let's start to dig into these kind of one by one. We're going to start with our cognitive changes and executive function and also looking at dementia because as OTs, this is definitely in our wheelhouse and something that we have to address within the team setting. So what's interesting is it used to be thought, if you look back to James Parkinson's lecture on the shaking palsy or his paper, he really believed early on that cognitive changes weren't really a problem so much with Parkinson's. They thought of it more as a motor issue. And even now, a lot of times clinicians think that it's more something that you see later on. But Dan Weintraub, who's cited on this slide at my site, and is an amazing neuropsychiatrist, really uncovered that early on, even, sometimes pre-Parkinson's diagnosis, people start to note impaired processing speed or that bradyphrenia, attention deficits, difficulty with visuospatial issues. So, really mapping their environment, parallel parking, things like that. Executive dysfunction we'll get into more. So complex, step following, sequencing, initiation and planning, and even some memory, more working memory impairments. And where we see that impact process skills is their problem solving often is really affected. So they might not understand or really be able to figure out how to initiate or solve a problem. Multitasking. If you think early on in Parkinson's, often these individuals are still working. And I don't know about you, my life right now especially is a lot of multitasking. I think we all are challenged with that. And that starts to become more and more problematic. They have difficulty with mental flexibility, so being able to shift back and forth between tasks and really look at multiple solutions to a problem. issues with decision making, and then also more and more difficulty with planning and organizing. So I notice this a lot anecdotally with my clients when I'm dealing with patients who are newly diagnosed, still attempting to work and maintain their family life, and they start to really have some issues that might not even show up on a MOCA as a cognitive quote impairment, but they're noticing a subjective decline in their cognitive function. Okay, so when we think of executive function, I think we all know this. These are kind of the steps here on the left. They have to be able to identify a problem, really plan a course of action and initiate it, self-evaluate, and look at more flexibility with their solutions. And what we know too is on the right-hand side here, executive function is impacted by all of these different elements that also come into play. So fatigue, which we'll get into later, and that's actually the most often reported non-motor symptom. That bradyphrenia that I mentioned, the attention issues or distractibility, they may start to perseverate on certain aspects of a task. There can be reliance on external cues and difficulty really initiating from an internal cue. They have more impaired access to working memory, and even that apathy or that decreased initiative can become a big problem for issues when they're approaching more complex tasks. All right. So then this can lead all the way into dementia, right? And this typically, it's important to note, is if we look at people later on, right? So this is not going to be early on in the diagnosis for most people. If you're seeing dementia and the person's just been diagnosed, we're probably looking at a different diagnosis, like dementia with Lewy bodies or maybe one of the atypical Parkinsonian disorders. So this is typically later on, but they'll have difficulty understanding directions or learning new tasks. There's a lot of issues with carryover and new learning. So if we're teaching them a home exercise program or teaching them a different way to do an ADL, that becomes really problematic. They have difficulty with awareness of their issues. They may not perceive that they have problems in some of the areas that their spouse or care partner is noting or that we're noting as clinicians. They might have difficulty even understanding utensil use. So that's where jumping to a compensatory measure like an adaptive utensil with someone with dementia might not be the best idea, because then they're having to relearn and do something new. Their feeding behaviors can be impacted by swallowing, efficiency, and safety. So we'll start to see some issues that go across and counteract with our speech language pathology clients or colleagues as well. Okay, so what do we do about these? As occupational therapists, how do we approach treatment? So we'll take a look at some ideas here. This slide is taken from a panel from the Movement Disorder Society that really looked at all of the research on cognition and Parkinson's and came up with these recommendations. And so what they found is to really maintain cognitive health, it's really important that they exercise. Exercise is medicine. We don't have a lot of information right now on specifics of types of exercise. So they're just recommending that for older adults, they recommend according to the American Heart Association guidelines. We want people to stay socially active. Maybe they should join a support group or, interact more with friends or, be in a mahjong group, like whatever it might be. We want them to interact with others. It's important that they work their brain. So engaging in some cognitive exercises and training can be important. And this isn't necessarily to remediate deficits. There hasn't been evidence shown that we can work on memory, for example, and improve their memory, but more that you're really trying to use this as a brain health or brain fitness activity. I thought it was great that they gave a shout out to OTs in this panel. They thought they should learn strategies with an occupational therapist for working through some of these deficits or impairments. Nutrition is thought to possibly be a help, so they recommend a Mediterranean diet. And the big part is taking time when doing tasks, because a combination of the bradyphrenia, bradykinesia, everything is slower. We're going to get into some ideas for time pressure management in a little bit that really help as far as pacing their time. So if we look at advanced stage, the panel went a little bit further, right? And so they said for someone with more mid to advanced stage disease, looking at those earlier recommendations that I just mentioned, plus developing a highly structured daily routine. So knowing what's coming, what time are they doing their exercise? When are their ADLs taking place? This becomes more and more important. They need to discuss the use of medications for any cognitive impairments with their attending neurologist or movement disorder specialist. And then at this point, it becomes really important to address issues with caregiver strain, because that can start to impact not only the health of the caregiver, but the assistance that the caregiver is giving to the patient with Parkinson's as well. All right, so if we look at some strategies around this, when we're training them in those activities of daily living, like dressing or eating or instrumental activities, we might need to increase the length of time of treatment. So this may take longer. We might have to see them for more visits. We may need to reduce distractibility in the clinic. I know in my setting, sometimes it gets pretty crazy, probably for some of you too. So a lot of clinicians in one room and a lot of activity going on. So sometimes I have to take people into a private treatment room to really reduce that distraction. I have to be really patient and allow more time for that auditory processing piece. So I tend to give a cue or command and kind of wait and see how long it takes them to process. And that gives me a lot of information about how much time I need to allow and what I need to train the care partner in their allowance at home as well. More modeling of exercises and strategies becomes really important, because if you think about it, watching you model and following a verbal cue can almost become a form of multitasking. So the more we can kind of demonstrate and be the change we want to see, and less explanation helps. And then repetition, repetition, repetition. You've got to really make sure that they practice it not just until they get it right, but until they can't get it wrong, and try to keep it as simple as possible. So some other tips for changes in higher cognitive function. So for these people that maybe are a little bit higher functioning, make sure you direct your treatment toward patient-centered, task-oriented goals. We want that salient piece, right? We're not going to work on handwriting if that's not important to them. We want to prioritize their goals. So whatever it is that they're having issues with, self-management, dressing, feeding, handwriting, that's what we want to hit. And we may need to do some direct training in cognitive strategies that I'm going to get into a little bit more. All right, so we also want to think about their environment. Schedule their treatment during the best time of day. Make the environment welcoming and motivating. We use music a lot in our site, and not just music that I want to listen to. I ask them, what do you want to listen to today? What's the last concert you went to? I'm also going to help them create a schedule. So if I'm trying to get them to do their home exercises, this came up recently with a client. He was continually not doing his home exercise program. So we made a day and time. And then I also said, I want you to email me when you've done your exercises, and let me know that you did them. So I created a little bit of accountability in with that schedule as well. Also with the family. So maybe they have to check in with family or friends and involve them into it. You might need more support initially to convince them that those carryover treatments are going to really target their function and improve their quality of life. So this is a research study that came out of Washington University, I believe, and Gedecken and Foster. And so looking at perspective memory, which can be an issue. So remembering to take medications or do their exercises at a specific, moment in the future. So they had people create what are called implementation intentions. So they asked them, what do you have to do? They had them specify the action. Where do you have to do it, or when? And then developing an intention statement. So I give the example here of, after I eat breakfast, I will do my LSVT big exercises. They had people repeat the statement several times aloud as appropriate, and they actually had them visualize themselves. So there was a little aspect of mental rehearsal. And my daughter's a musician, I was a dancer, and that visual, rehearsal, that mental rehearsal, we know from a lot of sports and athletics really helps. And it seems for our individuals with Parkinson's, it was helpful as well for them carrying it out in the future. All right, so if we're looking a little bit forward then, more into our Parkinson's disease with dementia, which is what PDD stands for. Like I said earlier, we want those familiar routines. We want to make sure that we store things in consistent places that are predictable, make sure the activities are really meaningful and salient to the individual. We might need to mark activities or tasks with pictures or labels. Look at gradual transitions, and music can really help with this. So, if I'm in the other room and how do you know that Law and Order is coming on or a certain television show? We hear the song and we start to really correlate it. So I've trained a lot of my individuals with Parkinson's and their family in using music and kind of linking music with different tasks that the individual is going to do. Coach in frequent reorientation to the day, to the task, to what's going on, maintaining a highly visible schedule and maybe even a calendar on the refrigerator. Make sure there's not a lot of clutter and distractions around, and then creating and maintaining some sort of an activity box, because it really helps, especially with things like sundowning or getting into more like psychosis and delusions. Keeping the person a little bit more active or engaged is very helpful. All right, so let's start to look at some of these changes in mood that we know happen. So depression, anxiety, and apathy are very common non-motor symptoms that really impact our treatment goals, and also so many elements for engagement and participation for individuals with Parkinson's. So if we look at depression, I think we, all are kind of familiar with this. We're talking about that loss of joy, feelings of isolation, and a loss of self-efficacy or feeling empowered to be able to do what you need to do. They may not really feel like they want to start or participate in activities. And this can affect their engagement in treatment sessions or even showing up or complying with therapy. And it can make your carryover more challenging. So you might notice that people just don't want to try. And we know too that depression and anxiety really impacts cognition as well. It serves as a form of internal distraction and can impact their overall quality of life. So then let's take a look at anxiety. A lot of us might be feeling this right now. I know over the last week, mine definitely spiked a lot. So we might see that people start to withdraw from communication and different social interactions as well. Sometimes there's a feeling of hopelessness that they can really improve their occupational performance or have that change in participation. Maybe they really have lost their sense of empowerment over their obstacles and their belief in themselves. So it's often seen that your patients might default to kind of a low energy, even though you see that they have greater capacity, and they might even start to withdraw from things that are meaningful to them, from different social groups or activities or engagement that you know that they enjoy. So then what do we do about this? How do we engage with them as occupational therapists and really help overcome kind of these obstacles of mood changes? So the most important thing is to really look at what is salient and engaging for them. Make sure that the tasks that you choose are meaningful to them. I've had so many individuals in that, oh, they have such apathy, they're so depressed, they don't want to do anything. The care partner saying, when I really dig in there as an OT and I put my OT hat on, and I know all of you out there have this ability too, and you find things that they've done in the past, things that are meaningful to them, and you really help them find it. It's so great to see them come out of their shell, because the more you link their program to those functional goals of wanting to be able to go walking with their buddies or play golf or interact with family more, it's really going to help their buy-in. If you can look at, even previous hobbies and passions that they've had, and help them, have this self-realization that they can improve their function and their participation, it really supports that empowerment for the individual to engage in those occupational roles. I've had people come in that will say, I can't do art anymore. I can't paint. I can't write. I can't do this. Well, I'm going to look at a task-oriented approach. I'm going to center my treatment around that. So, okay, how do I get this person involved in that again? Do we need to find a different medium of art? Do I need to find a different craft or hobby? Do we need some supports? A woman recently, it was literally just getting arm support while she was painting. When she was doing some of her needlework, you know, those boppy pillows, if you've ever had one of those for nursing a baby, having the arm support of that when she was holding her needlepoint activities and getting her posture supported, and even working through the fine motor amplitude activities and big, she was able to get back into that activity. And it really was a game changer for her. So this is what I mentioned earlier, this concept of time pressure management that actually comes, I believe, from brain injury research. But we're looking at, you know, how do we assess someone's time pressure in their daily life? So I think about when I was getting up and going to work before this all happened, I knew the exact time I had to be in the bathroom, right, to try to get ready. If I didn't make it in the bathroom at that time, I would not be on the train. I would not make it to work on time. So then I think about my patients and everything takes longer. So we're looking at what are the compensatory strategies that they need to deal with that time pressure management. But they have to recognize a deficit and a need for change. You really need that buy-in so that they can recognize and start to have some awareness and anticipate and use the strategies that they need to be able to overcome that. So they've got to have that level of motivation. And then I always make sure that I adjust that training around their individual learning ability. Sometimes I have them time themselves, or they're taking a shower or getting dressed, and look at how long that took and how long they've been allowing. And they're like, oh, wow, I'd only been allowing 30 minutes and it actually takes me 50 minutes now. And I didn't realize that. So this is a great strategy to use for your, to people to help them feel a little bit more empowered for dealing with those challenges. Okay, so lastly, let's get into fatigue and sleep disturbance on my end. Like I said, fatigue is very common. Let's go ahead and launch into it. It is the most often reported non-motor symptom for people with Parkinson's, and the one that people report to be most debilitating, and also the one with research we know the least about. And it does make everything harder. So it affects their motivation, it affects their engagement in, you know, therapy and social engagement. It can be both physical, so their body can feel tired, and they can, you know, maybe not feel like they want to do their exercises. But it also can be cognitive. So if they're on the computer for extended times or paying attention in a conversation, it can really interfere on both of those levels. We also know that it can interfere with their carryover and treatment strategies. So the things that you're teaching them, a lot of times they're like, I was just too tired to practice. It seems to interact as well in the research with freezing of gait and also vision, which is really interesting. So this is something we definitely want to check on and make sure that we're addressing for our people with Parkinson's. So then sleep disorders. We know that people can have daytime sleepiness or somnolence, nighttime sleepiness. They can have REM behavioral sleep disorder. From this, we see reduced concentration and memory. We know that if people are not getting adequate sleep, it impacts their motor learning, because there is an element within our REM sleep that supports the, you know, part of motor learning, and really that solidification of that learning retention. And also airway clearance can be impacted. So it can affect so many things. And sleep is a really big issue with Parkinson's. So then we come back to it again. What do we do about it as OTs then? We know it's a problem. Now, how do we address it? So let's look at fatigue. Believe it or not, in the evidence, the thing that comes up over and over is exercise. And anecdotally, I can say this as well, where I really see with my individuals with Parkinson's, if I can get them on a good balanced routine of exercise, it helps them so much. Keeping mentally and physically active is really important, but within measure, and we'll talk about that. We also want them to establish good sleep habits and good sleep hygiene. Not, you know, sitting there with the television on all night is a really bad habit that people can have, or going to bed at different times, getting up at different times. So I'd encourage you to look at the Centers for Disease Control for sleep habits and sleep hygiene and really focus on those, because I'm amazed at how poor some of the sleep hygiene habits my patients are. Avoiding frequent naps. A nap a day, the research suggests, is good, but limiting it to around 20 to 30 minutes and not too late in the day. Once again, eating well. So sometimes people will go all day long and not eat, or just have coffee or sugar and not be eating well enough to really give them energy. And it's very important to look at how they're pacing their day, what their routine is like, so they're not really going full speed ahead and really burning the candle at all ends and then crashing every day. All right, so with that, I am going to hand it over to my colleague, Erica, so she can talk with you guys about visuospatial deficits and beyond.
Thank you, Julia. Welcome, everyone. So happy to be able to be a part of our virtual AOTA event this weekend. Again, my name is Erica, and I'm an occupational therapist in Milwaukee, Wisconsin, and a faculty with LSVT Global. So thank you for being here tonight. So I'm going to talk to you about some additional non-motor symptoms. As Julia got us started on quite a few, we have a few more left that we're going to talk about, and then we're going to be ending with a case study just to demonstrate how you might be able to put all of these things together. So let's talk about visual spatial deficits and somatosensory issues. So some of the visual spatial changes we might see in people with Parkinson's disease can be observed in some of the examples that you see even in just a simple clock drawing that we note at the bottom of that slide, in that there's some difficulty with motor planning or utilization of just environmental information that is taken in visually to be able to apply that in the environment. So typically visual acuity is not part of these issues, and that it really is more of a motor planning and kind of a getting the visual information all put together and concise in the brain, and then bringing that to function. And as Julia mentioned earlier, vision can be impacted by fatigue. So a lot of these non-motor symptoms tie together. And so freezing of gait is one of the other things that can be impacted by this visual spatial change as well, in that the change in the environment, say the change in flooring, carpet to tile flooring and things like that, and it may just cause some difficulty in continuing fluid movement. Also postural instability, balance related things in just knowing where they are in the environment, causing some balance loss as well. So in individuals with Parkinson's, they have not just this motor problem that we've been talking about, but this sensory kind of motor problem where they're not integrating the sensory information that's coming from their environment, or even within the brain, it's not being integrated together to produce normal size movement. So we see that slow movement or small movement. And when we try to have someone move within normal limits by cueing them to say move bigger, they perceive that as moving in an exaggerated fashion or too big. And why do they not correct that on their own? Why do they not increase the scaling of their movement? Well, it's because of that difficulty in integrating that information. When we have a lack of dopamine, those movement plans don't come out correctly. Our body orientation isn't perceived correctly, and they do not correct those errors easily. So what do we do about that? So let's talk about some potential treatment strategies. So first, in addressing some of those sensory motor integration issues, we want to think about the individual's kinesthetic awareness. And so because the person likely doesn't perceive at least the extent of their movement and postural deficits, we want to help them to learn how to correct for that mismatch. So we call that the sensory motor mismatch. And so we can use a lot of education in regards to just explaining that it is going to feel a little bit awkward. They are going to be pushing themselves a little beyond what feels maybe natural, and that actually is coming out with a normal movement. And in LSVT Big, we call that calibration training. So we're trying to overcome this problem with the internal cueing mechanism by giving them lots of feedback, lots of repetition, which is something we call stabilizing in LSVT Big, in that we're trying to stabilize that performance to calibrate this new performance, which is normal sized movement. So we're going to watch a video and then we'll talk about it. It is cueing a patient to move bigger, and then I'll explain after we watch the video. So what you're seeing here is a gentleman who is walking at his comfortable pace. Okay, back and forth in the hall. You can see his posture and his steps, and just some bradykinetic or hypokinetic arm swing as well. Now, one of my colleagues is going to be cueing him to go crazy big with his movements. So as big as he can make it. Bigger, the better. Crazy big. Okay, and what we can see is, if the video on your end is smooth, hopefully you're capturing the moment here, is that he is getting more swing, larger steps, longer stride, more natural gait. And so when we cue someone with Parkinson's to move crazy big, what happens is they actually come out with normal movement. However, to them, crazy big feels crazy big. But to us, observation, to their significant others, friends, family, it looks normal to them. So it's very hard for them to produce that movement, at least initially, on their own without cues. And in LSVT Big, we work very hard on trying to recalibrate that, as we talked in the last slide. Some of the additional things to think about in regards to the visual spatial deficits that I talked about earlier, some of the things we can do is to promote some contrast in the environment. So making sure that that can help someone discern the environmental potential hazards, such as rugs or narrow spaces, as we know that can cause some freezing and things like that. So modifications to their environment to support safe mobility within the house as well. Using external visual targets can also help with visual spatial awareness in helping someone realize how far to step in a certain scenario. That also helps with kinesthetic awareness in addition to the visual spatial. And then adequate lighting, low vision strategies, lighting up hallways in the evening so that they can see where they're going and such. Okay, let's move on to pain and orthostatic hypotension. Pain is very common in people with Parkinson's. Approximately 76% of people do report having some sort of pain, and it does correlate with depressive symptoms and poor quality of life. It can be due to multiple reasons: dystonia, it can be neuropathic, radicular, musculoskeletal. And orthostatic hypotension can be part of a side effect of medications or just part of the disease itself. And it can lead to all kinds of problems in regards to fall or fear of falls and increased mortality. And the prevalence of that is approximately 30% in people with Parkinson's. So what can we do for treatment? What are some simple suggestions we can give our patients? So exercise is excellent, as we know, for pain in any condition. We want people to move and be active. And a lot of times individuals with Parkinson's tend to use one side, at least initially, a little bit less than the other. And in general, they tend to be a little bit more sedentary. And so we want to facilitate the use of their affected side, maybe a little bit more, or just generally encourage movement and exercise. And then of course we can train proper alignment, body mechanics, and posture during exercise and during functional tasks, things that are important and salient to them. And doing that in a repetitive nature to try to really get that calibration, getting them to understand how to obtain those movements with good posture and good body mechanics throughout all the things that they enjoy doing. And then educating in safe postural transition strategies is very important for orthostatic hypotension because we want people to be at less risk for falls. So taking it slow on the way to standing, taking a moment once they stand just to kind of regain themselves, and even increasing hydration, say before they come in for exercise for therapy or before they get their day started at home to help with increasing their blood pressure. And something to be watchful of or to ask about is sometimes individuals do avoid that hydration because they have frequent need to use the restroom. So I'm going to talk a little more about the bladder in a moment, and that is something that may be affecting their ability to maintain a good blood pressure. So let's talk a little more about bladder and bowel and sexual dysfunction. As Laura mentioned, I am a pelvic rehabilitation practitioner, and so this is one of my other main areas of specialty, and I take great interest in helping people with Parkinson's in these areas. There are not a lot of people out there that work with individuals with neurologic conditions that have these problems. So the first few slides, as we get to those, are going to show some information about prevalence in the population of people with Parkinson's. So this was a survey-like study that looked at men and women and looked at a group of Parkinson's individuals as well as a control group. And so the most common things that we see, especially in women with Parkinson's, is that they complain more of urinary urgency, of nighttime frequency, and having a weak urinary stream in comparison to that same control group in the general population. Additionally, for bowel symptoms, constipation being extremely common and difficulty expelling stool, those are even sometimes seen in the prodromal stage of Parkinson's when they don't even know that they have yet had Parkinson's. Constipation can be seen up to 20 years prior to the diagnosis. Additionally, women do report decreased libido and decrease in sexual intercourse, but as you'll see in the next few slides, men have more sexual dissatisfaction than women. So as far as men, they have similar bladder difficulties as far as urinary urgency, nighttime frequency, and having a weak stream. People with Parkinson's tend to have smaller bladder capacities, where they have more of like a sensory urgency and they need to go often. And when I have them measure what's in their bladder, typically it's much smaller than what the average person or a control group would void. And then again, men with Parkinson's have very similar complaints as women: constipation and difficulty expelling stool, much more significant than the control group and age-matched group. And then as far as sexual dissatisfaction, as we see on the bottom, men with Parkinson's disease have many more complaints about this and a lot more dissatisfaction as far as libido, decrease in frequency of sexual intercourse, orgasm, and erection. So what can we do? What can I give you some ideas for maybe some simple things you can provide to your patients for help in this area of treatment? So as far as bladder, they have done a few studies on use of behavioral retraining. So some simple therapy options that we can provide in brief, or with a specialist like me for someone that could go even into a little more depth with them. So a gentleman named Vaughn has done 2 studies on behavioral retraining in people with Parkinson's disease and pelvic floor therapy, and it's been very successful. So individuals with Parkinson's do not do well with the medications that are typically used to treat kind of overactive bladder symptoms in other individuals. It tends to cause more constipation, which is extremely common in people with Parkinson's, as we saw, and it also can cause cognitive deficits to be worsened or more challenging than they would have been if they already have some cognitive deficits. It really can enhance that. And so we want to look at some easy things to do. Laura, could you go back to that one slide just very briefly for me? So one of the things to think about is that we want to think about having someone consider eliminating constipation, as that will help their bladder. So encouraging that water intake and exercise, and I'll show you some things on the next slide. But also thinking about some adaptive equipment, you know, even having a commode nearby, especially for the evening time, and urinal potentially. And always thinking about the functional aspect of it, the motor symptoms. How are those motor symptoms affecting that person's ability to get to the bathroom? All right, so let's look at the constipation, kind of some suggestions there. So increasing water intake, again, we may have to think about, are they able to control their bladder or not? And should we, you know, encourage that without talking to them first about helping them with their bladder, because that can be a real challenge. But like we mentioned, water intake, very important for the blood pressure maintenance as well. Encouraging fiber intake, but that requires the water to make it as successful as possible. I always talk to individuals about making sure they take time to use the bathroom. A lot of people don't take time. If they don't have the urge to go to the bathroom and have a bowel movement, they won't take the time to go. However, that gets them in a bad pattern of not going at all. Warm drinks can help get things going in the morning, sometimes coffee for some people, although that can be a bladder irritant depending on the person. And or some breathing and relaxation techniques is a common thing that I will talk to them about. Even diaphragmatic breathing would be something very easy to instruct them in. There is some research on abdominal massage in people with Parkinson's as well. And exercise, like we've been talking about, staying active. LSVT Big can be an excellent way, one way of exercise that we can use to keep people active. And another thing that we mention here, sexual dysfunction. A lot of times healthcare practitioners tend to not bring this issue up. Maybe they don't think there's anything that they can do to help, but individuals do tend to want to discuss this if it is brought up. And even if you don't have the answer for them, you can definitely refer them to someone that does. And I hope that you have individuals in your communities that have some knowledge in this area that you could potentially refer to. So some of the things just to consider in regards to sexual dysfunction is that these individuals are experiencing all these non-motor symptoms that Julia and I went into in depth today, and all of them significantly affect individuals' libido or interest, or maybe even interest in each other. So like the spouse has now become potentially the caregiver and things like that. So just kind of thinking about how all of these pieces go together in affecting their ability to maintain that sexual relationship with their partner. And the other thing to consider is sometimes individuals now aren't even sleeping in the same bed because of sleep disturbances. And so if that's the case, maybe that's how you gently bring up the conversation, like, oh, is that a significant effect on your relationship? How are you guys doing? And something like that, just to kind of bring up the topic to see if that might be of interest, and maybe we refer out for other individuals to help them. So the one thing that Julie and I wanted to make sure that we brought into the picture here is that we know that we brought a lot of ideas to you guys today, and that we don't want you to get lost in all of these issues. And that really our end goal is that we're trying to help individuals with things that are salient to them. So we have to get to know our patients just like we do, and give them the greatest gift we can give them, help them with their independence, increase their participation in the things that they enjoy, and help them in their quality of life. And so once we figure those things out, then we can find the barriers. And all of these ideas that Julia and I gave you today could help remove those barriers to increase their participation in the things that they want to do every day. So let's talk about a case study. 74-year-old man, we're going to call Peter, was diagnosed with Parkinson's 5 years ago, and he's a Hoehn-Yahr stage 3. Bradykinesia, hypokinesia are impacting his ability to get dressed, do fasteners, put on socks and shoes, transferring from low or soft surfaces, walking in his home and in the community, and he's less interested in all of his hobbies, seeing his grandkids, traveling, going out to eat with his friends. And he doesn't exercise currently and had not had any therapy for his Parkinson's. So some of the non-motor symptom challenges that Peter is facing is that he's having trouble with dual task challenges, and slow processing and divided attention. He is not enjoying the activities that were once pleasurable, and he's not motivated to do much of anything, feeling very tired often. As Julia mentioned, this is very debilitating, and we don't know a lot about the fatigue. And he's not sleeping very well, restless legs, and he's getting up several times a night to urinate. He has chronic low back pain, so he takes it easy a lot and gets dizzy sometimes when he stands, so he spends a lot of his day watching TV, and he admits he has slowed down some, but he also thinks his wife walks too fast. And that's a common thing that we often hear, is that other individuals are noting it from the outside, but the individual with Parkinson's feels like they are actually moving normally, as we mentioned before. And then when we asked Peter about his bladder and bowel issues, he just basically said that he does like to stay near a bathroom. And so that can be obviously very limiting for people. So Peter went through LSVT Big 60-minute treatment sessions as per protocol, with 4 consecutive days a week for 4 weeks. And so with Peter, high amplitude exercise with task-specific training per the protocol of LSVT Big, which was delivered by a certified occupational therapist. And so let's look at Peter's non-motor symptoms. And so as he's going through LSVT Big, what we can kind of think about is how might we address these non-motor symptoms while treating Peter with 4 weeks of LSVT Big. As you know, if you are certified already, there is not a lot of time in the session. We have a lot to get done, a lot to get through. And so how can we address these issues during that intervention strategy? So when we think about cognition, dementia, okay, we can think about, okay, if Peter is having those issues, which we know that maybe he's having some mild issues with attention, as we mentioned, maybe we keep the environment very quiet, make it very simple, and our cues are also very simple and direct, and we use them redundantly and repetitively so that he has the same cue and gets that repetition to try to calibrate his movements. We use a lot of modeling because, as we know in LSVT Big, one of the big things is using our body to show individuals how we want them to move. A lot of cognitive cues can make it much more difficult to follow through with the activity, or it can make it confusing, it can make motor learning very difficult. And so using our body to exercise with him is one really, really good way. So we're addressing the cognitive deficit right along with our LSVT Big. Additionally, we want to use some of the tips for setting schedules as far as if there's some difficulty in getting the schedule or the intention of exercise going, using maybe the Homework Helper DVD. We have the Homework Helper LSVT Big DVD that could help follow along and keep him on track. Additionally, we want to increase the difficulty with cognitive tasks in real-world scenarios. So trying to add on small little layers of cognitive dual task challenges with a motor task to try to challenge that cognition. Whereas maybe prior to more recent literature, we may have kept that split up and not challenged that individual, but we know now that really the challenge is what they need in order to help them improve, because we typically in life don't just do one thing at a time. And then how would we address depression, anxiety, or apathy during LSVT Big intervention? So we want to use enthusiastic, motivational cues, and we want to drive their effort in things that are salient to them and use meaningful functional goals. So we choose things that Peter mentioned he likes. So he likes to travel, he likes to play with his grandkids, he wants to eat out. So we use those things to help drive his interest and drive his ability. And we teach him to use LSVT Big, or we use the LSVT Big protocol as far as utilizing amplitude, forceful or more effortful movements within those tasks. So we actually do the tasks that are important to him, ideally addressing the depression or anxiety or even just the apathy of that he just doesn't have interest in those things anymore, but find where that interest is. And like Julia mentioned earlier, if there's difficulty doing the task, maybe we have to find a different way of doing it and adapting it for their ability, and show them that they actually can still do what they want to be able to do. And then reinforcing, so lots of repetition and reinforcing that the effort that they're putting in is actually producing their improvement in the task or their ability to do that task. And, you know, admitting to them that, yes, this is hard work, but it is improving your ability and you're going to get to do all the things that you want to do. The more they can see that they can do it within your session, the better you'll be able to get that carryover outside of your session. And then fatigue and sleep disturbance. So talking about how, yes, you may be a little bit tired after exercise, but that's what's going to improve your ability to have more energy to do the things that you want to be able to do. And the better that the individual can sleep, so exercise may fatigue them a little bit more so that they can sleep better at night, following those sleep hygiene suggestions, and then they can have that boosted level of energy for the next day. When we think about pain and orthostatic hypotension, so obviously we do want to rule out other things that might be getting in the way, musculoskeletal conditions or whatever else might be causing their pain, and really see if there's anything else that we need to, if we need to refer them to someone to address that, or we need to address that outside of the LSVT Big treatment session. But not ignoring pain. Obviously, we want to maintain good quality movement and biomechanics during our exercise and during their functional task completion. And then obviously, sometimes individuals will not have used their muscles in a while. As we saw earlier in the case scenario, Peter has not been exercising. So muscle soreness can be normal when you haven't been exercising in a while, and talking to them about pain versus muscle soreness. And then sometimes we do need to refer back to the physician as to if we note orthostatic hypotension is an issue, if we do a monitoring of blood pressure sitting and standing, but we may educate in, you know, drinking, say, 8 to 16 ounces of water prior to them coming to therapy so that they can have improved participation. Maybe the physician might recommend compression hose, and we may recommend rising slower from the chair, taking their time and giving them some compensatory strategies. And then as far as the visual spatial and the somatosensory retraining, we can give them video feedback. We can show them what they look like. We can give them the verbal feedback, show them what is not normal, and really let them see it, show them what show them what looks normal and get them to feel it so that they can sense that, and then have them do that repetitively over and over. And we reinforce that with positive feedback. Throughout our LSVT Big protocol, we give assignments every day for carryover, and Julia mentioned that earlier as well, carryover assignments that we want them to use those bigger movements outside of therapy so they can feel how it feels to move bigger in the things that they want to do every day to help them gain that confidence. And then for bladder and bowel and sexual dysfunction, we want to make sure that we don't ignore the complaints of urinary frequency, give some general tips and education, and potentially, you know, referral back to the MD for specialized therapy, and, you know, some other individuals in the allied health field that might be able to help in those areas. So just knowing when to refer can be really important because, again, we may not be able to address all of these things perfectly within the time that we have. We can refer to a large team of individuals. It takes a village to help a person with Parkinson's. We have a large medical team that we can utilize to our advantage, a large allied health team, as well as many, many people in the community, all working together to help these individuals with all of these symptoms that we've talked about today. There's a lot of different places you can get more education on non-motor symptoms so that you have more tips that you can give throughout your treatments with individuals. So the Parkinson Foundation offers an Understanding Parkinson's Non-Motor Symptom handout. The Michael J. Fox Foundation also offers some educational materials, and the Davis Finney Foundation. So those resources are there for you. So in summary, non-motor symptoms are really pervasive, just as much as sometimes motor symptoms, if not sometimes more. and they affect independence and participation in all the things that our patients want to be able to do every day in their life. And we can impact these symptoms both directly and indirectly during our treatments, as we mentioned some of the techniques you could use during LSVT Big today. You want to view them as a whole person, but obviously we need to focus on what we know best and the specialized ability that we have, and know when to refer and use the multidisciplinary team and other referrals as needed and as appropriate.
All right, thank you, Julia and Erica. The information you presented was excellent, and thank you everyone for typing in your questions. Just as a reminder, the next 10 minutes or so, we'll open it up for questions and answers. You can either raise your hand by clicking the hand icon on your control panel. At that time, we'll call your name out loud so that you can ask your question. And just make sure that your microphone is unmuted when you do so. We'll also unmute it on our end as well. The other way is by typing in your question into your control panel, and we'll be going through as many of those questions as we can here in the next 10 minutes. If we don't get to your question, still type it in or leave it on the survey, and we can answer it via email after the webinar. So I'm just going to open it up for some of the typed in questions first, and then we'll get to some hands that are raised in our audience. All right, so a couple of requests for the references that were on the slides. And yes, I think that between Julia and Erica and I, we can put together a reference list for you in the next couple of days. Some of the references are on the slides, but we can compile something for you. Here's a question about the toileting schedule, and I'll let you both decide who wants to take this. Maybe Erica. Do you usually assist with creating a schedule with exact times, or encourage toileting in periodic episodes, such as every 2 hours?
Yes, very good question. So in regards to that, if I was seeing someone outside of LSVT Big for pelvic floor rehab, I would be much more particular about how I would assign that, in that I would have them complete a bladder diary and typically actually have someone measure how much comes out of their bladder so I can look at it more closely. So I can make it more in-depth depending on the patient's needs. But if I'm just thinking about someone I'm seeing for LSVT Big and I want to begin to help them to improve on that, I would have them consider, first ask them about the frequency. Because sometimes people are saying, you know, they're going every half an hour, every 45 minutes, every hour, and finding out if they're going a large amount first. Because if somebody says they're going every 45 minutes and going a lot, you may not want them to wait that long. So it can be a little more complex. Sometimes I make it as simple though as trying to, because some people just forget to go and then the urge comes on really strong. So making it at, say, the time they take their medications, or as you mentioned, like an every 2 hour schedule. That can be really helpful for some people. But then again, having more in-depth assessment can be really helpful in making that more specific to that person.
Okay, Erica or Julia, this next one is for you, and it's kind of a two-part question by the same viewer this evening. Can you touch base on the cognitive training as you mentioned earlier, and which cognitive health tips related to Parkinson's could be used based on this research?
Sure. So as I mentioned, unfortunately, we don't have anything concrete. There have been a few studies that have looked at computer-based training, for example, or paper and pencil task. And what's interesting is even if people show some type of like immediate response to the treatment, it's not long lasting. So at this time, there are no recommendations that are coming out of the literature on specific, like, I'm just going to give some examples, but I'm not saying they're not, you know, they don't work, but like Luminosity or Brain HQ, there's nothing to support someone doing a certain type of computer-based training or paper and pencil task. What it is more is keeping the brain active and really encouraging people to do new and novel things. So I teach a Fit Brains class at our center, and basically I change the activity. Part of it we do exercise, because in the literature that is the thing that comes up more and more, is not just exercise, but also exercise with some type of cognitive dual task component to it. So I might do some of the big exercises, because all of my people have been through big, and add in, they have to name vegetables or fruits, or I associate one of the exercises with a number or a color or a letter, and then we have to utilize that. I did math equations recently, which was really mean. It was hard for me too, where they had exercises 1 through 5, and then we had to come up with different equations that would equal 9, and they had to do what the exercises would be. So they had to remember what was 4 and 5, or what was, what were the numbers that would come up with that. But then also, as far as brain health activities, I have a whole arsenal of games and activities that target visuospatial function, memory, word finding, different elements. And so it's just doing those activities. So there's not any evidence at this time to suggest a specific type of training or activity. I think it's more people finding something that they enjoy. I think that's also important, because like, I hate Sudoku. I think I'd rather be tortured than have to do Sudoku, but some people love Sudoku. So, it's really, I try to work with people on, this is what you need to do. You need to find something to challenge your brain. These are areas that I see that I want to focus on with you, whether it's executive function or visuospatial. Here's some activity ideas. What do you enjoy? What's going to kind of get you excited to participate? Sorry for the
Excellent.
vague response.
No, I think it's great. Erica, this next one for you, please. Do you find bladder dysfunction is something that's typically missed by neurologists?
I think that a lot of neurologists have such a short time in their treatment or their appointment time that they maybe don't even ask about it. So I think, yes, oftentimes it is missed. And we spend an hour with them in LSVT Big specifically, and so we can see if there's, going to the bathroom before they get there, and then going during our session or after. And so I think it is recognized by us more, and I'm sure Julie would agree. We probably recognize the non-motor features more in general, not just the bladder, but all of them, because of the time that we get to spend with patients. So yes, I do think it is missed often.
Okay, great. Another question, this is kind of an interesting question, so I'll throw it out to both of you. Years ago at a neurovision conference, possibly Mary Warren, the presenter, mentioned that people with Parkinson's may have inferior visual deficits. Have you heard of this?
Inferior as in?
Maybe like inferior visual field deficits.
Well, definitely there's oculomotor deficits that come along with Parkinson's as well. So that's one of the loops of the brain that is affected by the lack of dopamine. So what I notice sometimes is people don't fully scan their environment. They can have saccadic pursuits or kind of choppy visual pursuits as well. So definitely you see a lot of different visual issues, not just visuospatial, as we mentioned earlier, but oculomotor deficits as well. Some different issues with light sensitivity sometimes. I'm trying to think of some of the other ones. Visual hallucinations can be another one, or illusions. So they'll think that a blanket laying over a chair is looks like a monster, or sometimes people in their peripheral vision will see things that aren't there, and it's not truly a hallucination. It's more something looking like something else. So vision in Parkinson's is pretty interesting. Anything you want to add, Erica?
Just would add maybe like double vision or the need for prisms, things like that.
For sure.
Okay, great. We just have a few more minutes left, and I know there's someone in our audience that has had their hand raised for quite a long time, so I'm going to try to find you. I believe it's Renee Gilbertson, and Renee, if you still have a question, I'm going to unmute your microphone right now. It looks like you're self-muted. Do you have a question that you want to ask out loud? All right, you're on, Renee, if you want to ask. I think we can't quite hear you. We'll give you another second, and you can always type in your question as well. Okay, all right. Okay, a couple other questions, Erica and Julia. When doing cognitive training to improve prospective memory, is there a specific number of repetitions or process per treatment session to get a positive outcome?
If you're referring to using the implementation intentions, I think that it really does take pretty consistent, work. I would say within LSVT Big, for example, when I've used it, I usually about the first, I'd say week or two, because I'm seeing them 4 times a week, ideally. So I'm having them work on that with me, and we're kind of addressing when it's going to be, what it's going to be, what the implementation is, kind of practicing that. Like I said, creating some accountability if I have to. So I would say it probably takes, 4 to 8 sessions would be my guess, depending on the person. Some people take to it a little bit quicker than others. But yeah, I think that one thing I would say is kind of missing from how that research was presented is that accountability piece. I think you have to kind of make them accountable to you in some way, or to a family member, so that the carryover and the compliance really sticks.
Okay, great. And last question of the night, and if there's any others that have come in, we will answer those via email. Our listener says, great presentation. I'm interested in knowing more about the mild cognitive impairment and the relationship to work in terms of average time from diagnosis to cognitive impairment to the time when the average client can no longer work.
Oh, that's kind of a tricky question because it's very individual. And it not only depends on the individual, but it depends on the level of their work. I will say this, the thing that I have seen interact and exacerbate it the most is anxiety. So if you see someone start to even have a subjective cognitive impairment, so let's say they're just having difficulty with multitasking, for example, and they become very anxious about that, and they don't have strategies to address it, and they're really starting to feel self-defeated, and their self-efficacy takes a hit, those are the people I see feel like they can't continue to work, and it really becomes a problem. I think that if you can address it early and give them strategies and let them know that, for example, my friend's an astrophysicist who has Parkinson's, right? He never had to write a number down in his life. I mean, he could keep these numbers in his head that I could never hold on to. And he really fought using strategies. He's like, I could always hold on to these numbers in my head. I'm like, you're going to have to write them down. It's okay. It's like your brain can't do that now, but it doesn't mean that you can't still do your job. So with that strategy, he was able to continue working longer. So it really depends on what is the nature of the job, what strategies can you give them, can you help them not become anxious about it? Because once anxiety sets in, that one becomes really tough and makes it even more challenging. But I would say intervene early. There's the complex task performance assessment that you can do. There's different assessments that really look at work performance. And I think, talk to them subjectively about it. Even if, say, you do a MOCA, but the impairment doesn't show up, what are they reporting? What are they noticing that is affecting them being able to do their essential job duties? And how can you help with that?
Thank you, Julia. I think that sounds like a very wise answer. So with that, I'm just going to remind you of our next webinars. We have one tomorrow at 12 Eastern on interprofessional practice approach to improving occupational participation, communication, and mobility in Parkinson's disease. And then 2 on Saturday, one on the integral role of OT in Parkinson's specific rehabilitation approach, LSVT Big more specifically. And then we're going to have one just for students and faculty, open to both OT and PT, including OTAs and PTA students, on information on LSVT specific to them and how students and universities can participate in training. And I've listed the link here at the bottom. If you want to register for any of those webinars, there's a link via our blog. If you think of any other questions, please email us, and please do fill out the survey as well. I just want to say thank you again to Julie and Erica for your time and expertise. I know I always learn a lot from you, and I hope that you did too, everyone who's listening. Thank you for participating, and just remember that if you want a certificate for CEUs, please email us at webinars@lsvtglobal.com. And we'll email you a certificate that you can use for self-reported CEU if your state accepts that. And with that, I bid you good night, and we hope that we'll be able to see you tomorrow at tomorrow's webinar. Thank you.
Thank you.